All right. Hello, everyone. My name is Mallika Sabharwal. I will be telling you about my project with Ideas Lab. It's called Understanding Medical Mistrust in Smoketown. So here's a little outline. I'll get you acclimated to Smoketown, which isn't located too far from the health science campus. I'll go over some data from a windshield survey that I conducted and from a few reports. From there, I'll talk about what medical mistrust is, talk about the logistics of the project, and then we'll get some feedback. So, Smoketown, as I mentioned, is about 9 to 10 blocks away from the health science campus. It's bordered by I-65 on the west, Logan Street in the east, Broadway in the north, and Kentucky in the south. A brief history. It was established in the 1800s, post-Civil War, by freed slaves who relocated to Louisville. An interesting fact is out of all of the cities, there were about like 10 that were established by freed slaves, and Smoketown is the only one that's still in existence in Louisville. In 1883, the historic Presbyterian Community Center was opened, and it was a landmark within the community for people and youth to use the space. It actually recently shut down in 2013, I believe. In 1941, the Shepherd Square public housing complex was built. Then in the 50s, there was like a change in environment with urban renewal policies and environmental laws that caused companies to relocate and take their businesses with them, which contributed to an increase in unemployment rates and crime. In 1967, the Mallika Middle School was built. The school is currently a major math, science, and technology magnet school within the JCPS school system. And then in 2011, the Smoketown Revitalization Project was started. The Louisville Housing Authority was awarded a grant to redevelop the Shepherd Square public housing to a mixed income development. And it was completed in 2015. Some famous people from Smoketown. There's Reverend William Shepherd, who Shepherd Square was named after. He was a social advocate in the Congo, and he was also a pastor at Grace Presbyterian Church, which is still active. In the middle is Sarah Martin and Sylvester Weaver, who are blues musicians. They made a song, or they wrote a song called Smoketown Strut in honor of Smoketown. It's actually on YouTube if you get the chance to check it out. And then there's the hometown hero, Muhammad Ali, who actually trained in Smoketown before becoming a professional. Some demographic data to get you acclimated to the people in Smoketown. There's about 2,700 people who live there. There's a predominantly African American population at 80%. 46% are above poverty. The median household income is about $18,000. There's about 63% of people with a high school diploma and 10% with a bachelor's degree. So Dr. Katie Leslie helped me complete a windshield survey of Smoketown to help me learn more about the community and basically just observe the environment there. So we saw that there were bike lanes, even though they were shared with the cars. And there are people who use the bike lanes, obviously. The cars that were parked on the side of the street were a little older. Walking is a major form of transportation, and even when we went in the afternoon, it was overcast and people were still out. There are signs that direct motorists to the major highways, and there's also a lot of promotion of religious institutions and faith-based initiatives within Smoketown. On the top left here, this is the redeveloped Shepherd Square, and you can tell where like the newer part or where the redevelopment has kind of started versus further south in the neighborhood where the houses are a little more dilapidated and landscaping isn't as well maintained compared to like closer to the redeveloped area of Shepherd Square where the houses are painted and they look newer. And then there's also the Unity Monument in the center. It was built in honor of Muhammad Ali and his coach, Fred Stoner, and it's kind of like this little community gathering area. Ideas Lab actually had an event earlier in the spring there. And then there were also a lot of convenience stores, mostly that advertise like alcohol and tobacco products. There are also a lot of like used cars and auto shops around almost at every block, it seemed like. There were also a few like warehouses and factories. Some of them, I guess this one looks to be active, but some of them were like clearly boarded up and they had like graffiti painted on them and like parts were strewn about. And then these are some examples of like the redevelopment where you can tell things are being done in the community. So to the left is like this little fitness park. It was closer to the Shepherd Square building, but there's like signs on how to like use the equipment if people ever wanted to do like isometric exercises there. There's also some murals painted along the sides of buildings done by community organizations. And then also there's a change in like the advertising. You have like this dilapidated advertisement for tires versus a newer youth-centric, uplifting advertisement for kids in the community. This is some data from the Louisville Health Equity Report to show you some of the inequities in Smoketown. Some of this data is really appalling, and it's hard to like wrap your mind around, I feel like, but to start, the 5-year life expectancy in Smoketown is 69, compared to Louisville, it's about 77. The diabetes death rate is one of the highest in Smoketown at 82, compared to 28 in the city. The heart disease death rate is also one of the highest at 303 in Smoketown, compared to 181 in Louisville. Going further down, percent of adults in poverty is about 48% compared to 13% in the city. And then like percentage of households with no vehicle access is 47.5 compared to 10% in Louisville. So it's pretty obvious how this impacts a person's well-being and how they live their life. The Vision Smoketown report was a survey conducted by Kentuckians for the Commonwealth, and they basically tried to enable residents to still have a voice as the community was changing with the closing of the Presbyterian Community Center and the redevelopment of Shepherd Square. So when asked, name 3 things you like about your neighborhood, there were about 19 responses that said proximity to resources, including healthcare. The number 1 response, with 73, was quality of and numerous relationships with neighbors. So you can tell that this community is very tight-knit, and they appreciate their neighbors and being close to each other. 71% of respondents received healthcare services within 5 miles of their home. 29% traveled less than a mile to visit a provider. So proximity to the downtown medical center was identified as a community asset, yet many noted that accessibility to healthcare providers is a major concern. So this made me wonder, what are some of the barriers to accessibility? And this list is not comprehensive by any means, but just some things to think about. Some of the visible barriers are availability of an individual. Are they working at the time that a doctor is available? When is the doctor available? Do they have to take care, like what other commitments do they have that prevent them from going to go see a provider? Transportation is a major obstacle. And also like insurance and affordability. Is there a physician that's close to them in their network? Can they afford it? And then some of the invisible barriers are more behavioral and psychosocial in nature. And they come from like personal experiences of discrimination from seeing a provider or interacting with the office staff, and then also the history of mistreatment within the medical community from the time of slavery to the Tuskegee syphilis study, which may inhibit someone from seeing a doctor. So all of this kind of combines into this idea of medical mistrust. The Medical Mistrust Index was created by researchers to understand some of the psychometric properties that go into interactions that people have with a medical provider. And we'll go through each of these sections and survey some of the questions. So the first section asks about people's opinion of the healthcare system in general. So on the 4-point scale, how do you agree or disagree with patients have sometimes been deceived or misled by healthcare organizations, or when healthcare organizations make mistakes, they usually cover it up? The second section is healthcare utilization, and it asks about a person's interaction with the doctor. So the question asks you, during the last 12 months, was there any time that you did not come back for a follow-up appointment that your doctor gave you? Second question, I think there's about 4 in this section. Has there been a time in the last 12 months when you didn't follow the doctor's advice or treatment plan, get a recommended test, or see a referred doctor? In this section, it basically asks about negative experiences that a participant has had, asking them if they've heard of any from their relatives or of their friends. And it asks a little more in depth, like how long ago was the experience, and at the time, how did that experience bother you? The health behavior section asks about specific services that a person has had when they see a provider. So like getting a screening for colon cancer or an eye exam. And then the trust inventory assesses, I guess, like a person's general trusting ability. It asks questions, or it gives statements like, I accept others at face value, or it's better to be suspicious of people you've just met until you know them better. Perceived racism index, it asks about if the participant believes there is racism in medicine. So an example of a question, do doctors treat African American and white patients the same? In most hospitals, African Americans and whites receive the same kind of care. And then the last section asks about if the participant is familiar with the Tuskegee syphilis study. So just asking if they've heard about it and if they know like when it began or when it ended. So my project will implement this survey, and we will measure some of the goals are to measure the level of medical mistrust among Smoketown residents compared to University of Louisville providers and students. We also plan to expand upon a tool that's used by healthcare institutions to assess the level of medical mistrust among a population. And we also hope to create a more dynamic approach in addressing trust between patients and providers. So in a little more detail, when the first phase involves implementing the medical mistrust index, and we hope to recruit 10 providers or students within the medical community, and then also 10 residents of Smoketown, and to just administer the survey and see what the differences are, what the similarities are, and just to collect findings and see how it is between, or what are the differences and similarities between the two communities. The second phase is to use the results from the survey and create topics and questions to address in a focus group with the same providers and residents of the community. And the different thing about this is that instead of just having a dialogue, we're going to do a creative project. So the responses from the focus group will be collected either through writing or like painting the responses out. And both people will do it together. So there will be this creative project created by both Smoketown residents and providers or students from the medical community. And then the last phase is presentation and dissemination. So we'll share the results from our findings from the survey, and then also the creative project within the healthcare community and Smoketown, and even using it for like an activity in the cultural competency curriculum that we have here at the Health Science campus. Expected outcomes are to bridge an aspect of the accessibility gap. The medical community has realized that trust in the medical system is an issue in accessing care. So we hope to kind of expand on that by approaching medical mistrust in a more dynamic way versus the more quantitative survey. We hope to get some more qualitative data and understand the experiences and interactions people have had. And then we hope to redefine medical mistrust instead of thinking of it from patient to provider, but also thinking of it from provider to patient. Thank you. Ready?
Tell me more about the creative, artistic part of it. Tell me how that's going to work.
So it kind of depends from the survey. We'll see where the greatest difference, like if it's in the healthcare utilization section where we find that the providers are less, or the providers, if wherever there is the biggest difference, we'll kind of ask more questions about it. So one of the questions was, have you followed up with a provider? And if we see that a lot of people said no, we'll kind of like ask, okay, well, why is that? What were some other feature, or why did, like what prevented you from following up? And then the response, instead of just being a dialogue, it'll be like either writing like a diary or like a journal about it, or maybe even doing like a painting where they kind of express like how something different about like how, just, I don't know, it's like, we're still trying to figure it out. Okay.
I wondered what your inspiration for that, or what your thought process was, and why go that artistic, creative way, and just sort of a follow-up with the writing. It might be kind of challenging based on some of the demographics you gave about the education and so forth. So I wondered if I know it's kind of early, but if you thought about some of the hurdles you might run into, how you might address some of those, or just kind of want to pick your brain about it.
Yeah.
And if you don't have the answer, I understand. I'm trying to figure mine out too. So.
No, those are things I actually haven't considered, but the writing thing could be an issue. And I guess we can like ask participants beforehand if they feel comfortable participating in a project that requires them to write, or if they'd feel more comfortable doing something like verbal, doing like spoken word, an activity around that.
What was your inspiration for that?
Inspiration.
What informed you with this would be a good idea?
I think, well, I'm working with Theo Edmonds and Ideas Lab, and that's kind of their nature to do things differently, so that kind of was the inspiration, I guess. But medical mistrust is a huge issue in working with minorities and them and accessing healthcare, so it kind of came, and Smoketown is it's located right next to the health science campus, so like what are some of the other barriers for them? Thank you. Yes.
Did you say you're going to have providers in there too?
Yes, we
So
will.
where would you get them from since you don't have providers in Swanton?
Well, they would be from the UofL campus, physicians affiliated with the Health Science Center.
So would they be folks that actually provide care to this group? And why are you limiting it only to physicians?
Well, it won't just be physicians. That's a good point. I was trying to be neutral and say providers, but it won't just be physicians. It could also be nurses and other providers who would be interested. Sorry about that.
Public health is in that area. There are
That's true.
practice nurses in that area, or nurses that do provide care. So I would suggest you don't just limit it. The other suggestion, picking up on what John said, was photo voice. If you consider using a camera, these folks have smartphones or cameras, and that's another creative way of trying to express things. It's been used in the literature quite a bit, especially in low literacy populations.
That's a good point. Thank you.
A mural would be good.
You showed a photo of the mural.
Oh yeah,
We could do another mural.
I think that would be interesting. Having like side by side. Yes.
So you said that you're gonna have 10 people per group in order to take the medical mistrust quiz. Is that just how did you pick 10? I guess is the question.
Yeah, so we wanted to keep it small, a small cohort that we could kind of follow up with. If we have the capacity, we can make it more. I'd also like to incentivize the participants, so I feel like 10 is easier to incentivize compared to more. But we'll see, it might change.
I'm just thinking of in terms of statistical power, if you were to actually pillars.
That's a good point. So it might change. That is a good point. Yes.
I have a question. I may have missed it, but are you going to be looking at patient-provider communications and how, or just assessing for, is there some miscommunication that might happen, particularly in the literature? It talks about patient-provider communication can lead to mistrust. So thinking about diabetes and how there's such a difference in language sometimes in terms of what's colloquially used about addressing a particular disease or health behavior versus what is used medically, and how providers might not look you in the eye or talk down to you or use this language that's so different. And so I just wonder, is there that nuance in there about mistrust that could also be miscommunication or lack of
That's
good
a-
communication?
Right, that's a good point. And I don't think the survey really asks about that, but I think the focus group will kind of allow for a dialogue around miscommunication and what providers say and what patients hear. So definitely during the focus group, we'll talk about that. Yes.
I kind of had a question about your sampling. Like Diana said, it is 10 people, so it sounds like it's more targeted. So I guess what I'm wondering, are you trying to get people, like you suggested, who are already connected to each other in some way, where you may be trying to like repair or change their interactions, or is it just kind of going to be general? And I guess what I'm wondering is, with the focus group, is this more of a program aimed to change things, or are you trying to understand what the state of things is?
That's a good question. I think this is more programmatic and qualitative. We're not so much looking at statistics and analyzing numbers. And then also just understanding where the state of things are by providing this survey to providers and then also residents, and seeing where or how both representatives from both communities kind of score. But that is something to consider as well, if we should increase the sample size or like the size of participants.
You were just using that 10 and 10, so 20 total, as sort of a preliminary mining, just to see if there's some sort of trend, and then you're going to try to investigate those further with qualitative methods.
Yes.
Okay. Good.